Well, it will be another few seconds because I mean there's technical stuff and we're used to troubleshooting by now, but I can tell you it won't be ages. It's not the connection to South Africa this time.
Okay. Sorry, the sound is okay? Yeah. Thank you, everybody. Thank you for inviting me. It's a great honor to be part of this event of this faculty. And I will talk about the dyspneic patient. Dyspnea, what is dyspnea? Everybody, if you will know, what is dyspnea? So I tell you what the American Society of American Thoracic Society says. It's a subjective experience of breathing discomfort. So dyspnea is what the patient feels. It's not what we tell the patient he has. It's not a diagnosis. Sorry. It's not my opinion. It's just what the patient feels. If the patient says, I'm dyspneic, most patients won't say that. They would say, I'm short of breath, I can't breathe, anything like that. You have to believe him. It's his subjective experience. He feels the dyspnea. You can just say, well, I think the reason is, or perhaps the reason is just psychogenic, and I don't think you really have a problem with your respiration. But if the patient says, I have a problem, first you have to believe him. What can be the reason of that feeling for the patient? Reason can be from nearly any organ system, because dyspnea is generated in the brain of the patient, and he gets his information from the thoracic wall. There are some mechanoreceptors from the glomus caroticum, different chemoreceptors. So there are a lot of reasons why the patient can be dyspneic. Evidently, the lung is one of the big reasons, and those are the reasons that you will find quite often. There are some more reasons. I can't name everything because you will find it in the books, and it won't help you a lot, because if it's a disease that happens like one in 1 million, you won't see it too often in your clinical work. The big part for us pulmonologists is bronchial obstructive disease, asthma and COPD. That patient could have dyspnea. Why isn't it in red? Why isn't there a sign of sono for you? In COPD, in asthma, you can't use your ultrasound probe. You can use it, it won't give you any information. That's the problem. If the reason is pulmonary embolism, you use your probe. Peter will talk about that afterwards. You already heard a bit of it. So in pulmonary embolism, you can use your ultrasound probe. If the patient got pneumonia or bronchial infection, as long as it touches the thoracic wall, so it touches the outer edges of the lung, you could see it in ultrasound. You don't have to see it. You can't see it every time. It's just the same like pneumothorax. Most pneumothoraces, you know that, will be detectable in ultrasound, not all of them. Pleural effusion can also be a reason for dyspnea. Pleural effusion should normally be seen in ultrasound. As I've been learning thoracic sonography in Marburg in Germany, Professor Görg, and he always said the people who cannot detect pleural effusion in ultrasound lose the license to take the sono in your hand. So probably you will see that. I guess everybody will see it once you detect it. Yeah. And then there are some other reasons, like for example the non-cardiogenic pulmonary edema or ARDS. You could use the ultrasound for that. Probably you will have other problems with that patient, so you would perhaps not use the ultrasound in the first place. So that's the reasons why you could be dyspneic from the lung. Heart and central nervous system, two vital organs, so I put them first before the other things. Acute coronary syndrome can cause dyspnea. You all know that. The patient with a myocardial infarction often says, I have shortness of breath, I can't breathe, feel congested. Congestive heart failure also. Why is the one blue and the other one red? The red one is the one where you use thoracic ultrasound. The blue one is the one where you use cardiac ultrasound. In fact, it's just a question which probe you use. It's always the same machine, or nearly always. Cardiac tamponade, you have heard about that before. So in the talks yesterday, for example, I won't focus on that. And then there are some central nervous systems, neuromuscular diseases. You can also get dyspnea from that. Yeah? Patient who can't breathe because his muscles are not working anymore, like myasthenia or something, myopathy, they will also feel dyspnea, although the reason is not from the lung, although the reason must not be acute. Dyspnea can be acute or chronic. The next thing are the metabolic and toxic reasons. So patients in diabetic ketoacidosis, they will also experience dyspnea. Yeah? They will. How will they breathe? You all know that? Casmal's breathing, yeah? So, but he will experience dyspnea, although he doesn't have a problem with his lungs, he doesn't have a problem with his heart. What's his problem? The acidosis. The blood turns acidotic, so he has to change it, and that's why he hyperventilates. Patient in sepsis, that's, as you already know, something where you can use your ultrasound probe, and then there are some other rare reasons you can encounter in your emergency department when you're on the field in your emergency response car. So, for example, the intoxications, cyanides, carbon monoxide, as long as the people are alert and awake, they could tell you, I'm feeling dyspnea. So we have a lot of reasons now, and we have a big problem. The patient doesn't tell us, hey, doctor, I have this pathology, please tell me what to do. And then that's how you learn it in the books, yeah? This is the pathology, you take the history, you examine the patient, you look for signs and symptoms, and then the book tells you that's your therapy. Problem is that's not how you work, how all of you work when they are on the wards or in the emergency room or somewhere else. So you have to rethink the whole system. What's reality? Patient presents with the symptom, perhaps you have some history, you can look in the charts, you can look in the computer, you can ask the patient, can look for a more detailed history, you can do lab results, you can do laboratory exams, clinical exam, and then you have to say, well, I think it is either this or this or this. Perhaps you have experience, expertise, you say, I think the patient has, for example, when you do your exam, the patient you just had before, he has fever, he has hypotension, he's tachycardic, he's on the ICU, and you know, he had gastrointestinal bleeding. What else did he have? What was the history of the patient? Cardiac failure and sorry? Temperature. So you say differential diagnosis is shock, okay, shock anyway. It's either cardiogenic shock, it's hypovolemic shock, it's septic shock. Then you have to say, well, this patient doesn't look septic, lactate is not high, okay. Perhaps you use the ultrasound probe, you say, it doesn't have too much volume in it. I say it's hemorrhagic shock, let's treat him. That's my working diagnosis. You think, could it be really, or is it something different? And then you start your therapy. And sometimes your therapy will not be the right one. You have to live with that. Sometimes we don't know everything. But there are some possibilities how to find out what's really happening and how we can help our patient. So, some of you might know Raoul Breitkreuz, one of the godfathers of emergency ultrasound in Germany. And they made an analysis of classroom presentations. So what I'm doing here, that is how much you will know in 14 days. Not so much. You, of course, will know much more because you're a great audience. But in fact, many things that I say here will go in here and go out here. The things that you remember better are the cases. So I said I will bring you a good case, perhaps a good case, I don't know. I hope you will remember a bit of what I tell you. That is the rapid response car I was part of some years ago. And it was in about 3 years ago. I was going to a patient on a geriatric ward. So the patient was already in hospital, and I was going there with my rapid response car because it was not an acute hospital. Patient was 78 years old. That's something I know before I come to the patient. And when they called the emergency car, they said, increasing dyspnea for about 2 hours, and that's everything you know at the first moment. You go into the room of the patient, and you see the ambulance crew and a general practitioner who is on call in this hospital at work. You don't know anything more. What's interesting for you? What do you want to know for that patient? First thing is, get a view on him, huh? So, patient is on the ambulance stretcher, and he's greeting me. Doctor. So for those of you who don't speak German or who don't speak Austrian German, that's a quite familiar greeting. Apparently he knows who I am. He says hello, and he has big difficulty of speech because he can't breathe, probably. And I wasn't in the room yet. I was at the door. The patient was there on the stretcher, about 5 meters away, and I saw the abdomen coming out in the wrong time, so paradoxical breathing. And I saw his jugular veins popping out, even from the distance of 5 meters, I could see that. And he had an oxygen mask, and still his face was blue. And what else could I see? That's not often described in all these textbooks. The patient was really afraid. The patient was afraid that he would die now. So what do you do with that patient? You try to help him, of course. Why did the patient greet me so familiar? Because 3 weeks ago, 3 weeks before that episode, he was on my intensive care unit for 2 weeks. So I already knew him. That's an advantage. Normally you don't have that. I saw him I even knew when we were going towards the patient in the car, I read the name and I said, oh God, I sent him here. I know who he is and I know what will be his problems. So I already had a part of his history. If you don't know that, you just look in the records. He had COPD, and we established long-term oxygen therapy 4 weeks ago. Long-term oxygen therapy in COPD means at rest the patient has a PO2 in the ethereal blood of less than 55 millimeters. I knew he had cor pulmonale. I knew he had paroxysmal atrial fibrillation, and I knew that the reason why he was at the geriatric unit was pneumogenic sepsis. He had some 5-6 weeks ago, and he was staying in the hospital for 6 weeks now. So 2 weeks in another hospital, 2 weeks in our hospital, and then at the REMOP ward. And he had a prostate cancer at 78 years. That's often a chronic disease and nothing you have to deal with. So what do you want to know of that patient? What would you do? Sorry? An ultrasound. An ultrasound, okay. I was on the rapid response car. At that time, we did not have an ultrasound on that car. That's the problem. Blood pressure and? Okay. Saturation. ECG. All takes time. The patient can't breathe, doesn't get enough air. So, okay, yeah. We were looking. He was alert. He had prompt reactions. They were a bit slower, but nothing special. He had, as you already know, dyspnea when speaking. So he had dyspnea. I asked him, otherwise I could not know. If he just breathes a bit strange, I don't know if he has dyspnea. He said, that's really a problem. Okay, as long as he can speak, it's a good sign, yeah? I palpated his pulses. They were arrhythmic. They were symmetrical on both sides and a bit tachycardic. He had leg edema, no dermatosis, so no chronic dermatosis, but I knew the leg edema were still were not really acute because he already had them 2 weeks ago when he left our ward. So it's an advantage if you know that. If not, you have to deal with it. Yeah, leg edema still, there is something going on. Yeah, I tried to do an auscultation. He had a wheezing, left a bit more than right, but on both sides, in fact. Perhaps some fine crackles at the left base, but not sure. Yeah, it's loud. The patient is not very quiet. The whole room is not quiet. You have 4 people from the ambulance car. You have 2 nurses. You have 1 doctor from the ward there. There's another patient in the room. So you can just guess a bit. Yeah? Cardiac auscultation was not possible because the lung sounds were that loud. And his skin, the percussion, well, you do that very rarely, I think. Yeah, you should do that more often. So you wanted some results. I have for you a blood pressure of 110 to 75 millimeters of mercury. It is. Sorry, I didn't write it. He had a heart rate of 125 per minute, breathing frequency of 35 per minute, the saturation of 83, but the signal was weak. So we were not sure if it's true or not. And I took a temperature, 37.4 degrees. So no fever, reddish skin. What do we do? What does the patient have? What can we do now? What is our therapy? He's really, he makes horrible sounds when breathing. We don't know what he's doing. And he has a cyanotic phase. So we think if we don't do anything, if we continue like that, he will die soon. But he still can speak with me. Ultrasound? Not possible. We don't have it here. Sorry? Oxygen. Oxygen is a good idea. He already had oxygen via mask. So I turned up the oxygen. Okay. 15 liters per minute. Saturation was not going to more than 85, 87, something like that. Yeah. What else can we do? Sorry? We can give him volume. You think he needs volume? How do we know? He has leg edema. He has distended jugular veins. We don't know. We would need an ultrasound, yeah? So, you could give diuretics. The diuretics we can give, I think you're talking of furosemide or something, will take 20, 30 minutes until they're working, yeah? But it's perhaps an idea if you know. One says volume, the other diuretic, so that's the problem. We don't know what is really his problem, huh? We go back to that sign. We have some symptoms. We have a history. We don't have lab results yet. We had the blood glucose at that time. It was normal, or a bit higher, 200 something. Yeah? We have a clinical exam, and we have differential diagnosis. So in order to have a working diagnosis and to establish an emergency therapy, we need to know what are our differential diagnoses and then think what is the case, what the patient has here. What differential diagnosis would you think of? Cardiac asthma, so acute pulmonary edema, in fact, we say, yeah? Next possibility. Sorry? Pulmonary embolism, why? Does he have a risk factor for it? He has cancer. He was bedridden for 6 weeks. He has risk factors. We will come back to that again, yeah? Next thing. Pneumonia, yeah, he has a bit of temperature. He already had pneumogenic sepsis, perhaps it's recurring pneumonia. Either a new germ, hospitalism, or the other one is coming back, yeah. Decompensated, exacerbated COPD. The patient has COPD, we know that. Could be, why not, yeah? He's wheezing, yeah? So, what else do we have? He has a cancer, so he could have pleural effusion. He had some fine crackles at the left base. Perhaps it's due to that. He could have pneumothorax. Every COPD patient can have pneumothorax. Think about that. Yeah. He could have anemia. Somebody who is in the hospital for a long time, gastrointestinal bleeding from some ulcer you don't discover because it's just subclinical. Yeah. Should think for that. Anemia often causes dyspnea. What else do we have? Yeah. The congestive heart failure, so the acute pulmonary edema. He is tachycardic, yeah? So that's also a reason for it. And he could have an allergy. That's also something you should always think of in patients who are in hospitals. They get a lot of medications. We are the bad guys. Yeah? We give them something, they get allergic to that. Think of it. Could happen. So, what was I doing? I said, I don't know what's really his problem. And I know the literature a bit. The literature says acute respiratory failure in the elderly. The reasons are normally cardiogenic pulmonary edema. We were thinking of that. Community-acquired pneumonia, or in that case, perhaps hospital-acquired pneumonia. Exacerbation of chronic respiratory disease, pulmonary embolism. So we have everything that's frequent, and the rare things, we forget about them. Then we said perhaps pulmonary embolism. There is a score. When you take history, you can always do some scores. I will come back to that. This is the Wells score for pulmonary embolism. He had recent surgery or immobilization. He was immobilized. Well, he was on the mobilization ward, but still he didn't go so much. He didn't walk so much, so some points for that. He has a cancer, active cancer, and he has clinical signs more than 100 beats per minute. So this is 4 points. Wells score, 4 points means in the 3-level, either intermediate probability or in the 2-level stage, unlikely. So it could be embolism, it could also be something different. We don't know anything more with that. How do emergency physicians do with acute respiratory failure and dyspnea? Yeah. Sensitivity, specificity is quite low with all these frequent diagnoses, so the performance is not too good. That's a study from an emergency room, so we go back to the office. If the patient comes to your office, the first thing they want you to do is check an X-ray. Who does a conventional X-ray on a patient who has really difficulty breathing? Can't do that, in fact. Yeah? And that's the only German slide I have for you. You're not allowed to do it, because as soon as you have alternative possibilities to get your diagnosis, you're not allowed to use irradiation. Yeah? In Austria, that's not such a big problem. Hello there in Germany. There have already been people convicted, sued for using radiology in cases where it's not absolutely necessary. Yeah? So you should think about that. It's perhaps not good to take it in the first place. You could perform a spirometry. In a patient like that one, you cannot perform a spirometry. He will not adhere to the exam. That's okay. You could do an echocardiogram, but still that's only when chest X-ray is abnormal. So it's a bit strange. This tree here doesn't help us so much. You can then go on with ethereal blood gases, if you have them. I was in the rapid response car. We are fortunate we have that. Okay. So that was what I'm thinking about. Ventilation perfusion scan, cardiac catheterization, everything not really usable. Why? That's what you have in your emergency room. That's the the trauma emergency room in Graz, yeah, at the university clinic right here. What possibilities do you have here to assess your patient? Sorry? Okay, yeah. So I have here what we already had, blood pressure, saturation. You can even do invasive blood pressure. You can do capnography. You have a conventional X-ray. You have a mini lab, so at least ethereal blood gases. And what you can't see here, what could be inside here, is the handheld sonography. That's the tools we have to work with. We cannot take all the things they recommend here. So we have to work with that tools if we want to know what is the problem with our patient. We already took histories and we made a score with the patient. We can do a clinical exam with everything. We can do some tests that are on scene or either in the emergency department. You get the results within minutes. You could do big blood tests. Okay, that's another problem. Sometimes you can do them quickly. You get the result in 1 or 2 minutes. Sometimes it takes 20 or more longer. And for the imaging, you can do the sonography. You know, point-of-care sonography is possible. Chest X-ray, it's not that mobile and not that quick. And the CT, that's only possible for the colleagues in Berlin out there. They have a CT in the ambulance car. There's the STIMO, the stroke emergency mobile, I don't know what exactly is it called. Yeah. So they really have a CT inside their ambulance car. Or what Marcel showed you 2 days ago, there are emergency departments where you have the CT right in the room where you assess your patient. So that will perhaps gain bigger importance, but right now sonography is the only imaging we can use at that time. What of all these tools are really good for us and for our patient? So, blood gas analysis, you can use it in the field. There is evidence for it, and there is evidence that blood gas analysis tells you something in the dyspneic patient. What does it tell you? If the patient gets acidotic, his mortality is higher, but it doesn't tell you what is the reason for dyspnea. So we can use it. It will help us a bit. It will not help us too much. Sorry. Blood pressure. Blood pressure will only help you if you have a patient with acute heart failure, and that is the reason for the dyspnea. Then in the acute heart failure, you can say, well, that guides my therapy, the blood pressure. The problem is with blood pressure and dyspnea, what is the chicken and what is the egg? Yeah? Because if you have high blood pressure, you can get hypertensive pulmonary edema and being dyspneic. If you are dyspneic and your heart is working good, you will have catecholamine drive endogenous, so your blood pressure will raise. On the other side, if your blood pressure is low, you could get dyspnea, yeah? If your heart isn't working anymore. And if your dyspnea is really severe and you're really, say, if the disease, whatever causes the dyspnea, is really taking you far, so towards the end, the blood pressure will go down, yeah? So blood pressure and dyspnea can help us in certain circumstances, but not always. Should we do 12-lead ECG? Of course we should do it. It will take a time, yeah? If the patient is sweating, 12-lead ECG could take up to, let's say, 5 minutes to get a good recording. So, but you should do it, because if it's an infarctus, it's important. At that time in 2006, they said the mortality is not altered if you do pre-hospital 12-lead ECG, but that was 12 years ago. And that was at the time they were looking at systematic review at older studies that were dealing with thrombolysis, and that was not for people who were going to the catheter. And also in pulmonary embolism, ECG could help you. So you should do it. And what I wanted to say with these last slides is there are some myths in medicine. Yeah, everybody says the shocked patient should go in Trendelenburg position. Yeah, there is no evidence for that. The problem is there is even the possibility that this may be harmful. So your shocked patient should not be put in Trendelenburg position. Yeah, and it's the same. We don't know if blood gases, if ECG, if 12-lead ECG, if blood pressure really help us in the evaluation of the dyspneic patient. We think so. We try to make our picture and find out what's the real problem of the patient, but we don't know so much. So the Trendelenburg position is, in fact, not used so often anymore, or should not be used so often anymore. The only thing where you can use it and where it can help you is if you perform the passive leg raising test, which shows you volume responsiveness. Yeah. So sometimes it could be good to do it, but you don't know always if it's the right thing. So the only thing we have now that can really help us is the ultrasound. We hope. Let's look if we have the data to support that. There's been a study. Unfortunately, you don't see all of it. The first line would be combination of lung ultrasound, a comet tail sign, and terminal pro-BNP. What comes out here is on patients where you want to know if the dyspnea is caused by chronic obstructive pulmonary disease or by acute heart failure. The ultrasound has an odds ratio of 54, so it tells you it is this, the reason of the dyspnea is either that or that. But you don't have to buy an ultrasound scanner for that, because if you just ask the patient if he's orthopneic, you will get the same result. The odds ratio is just 7, but odds ratio of 7 is quite good. Yeah, and it's still highly significant result. So the ultrasound can help you. The question is if you always have to use it, and that's something that Peter will talk to you later. I think you've already heard of Daniel Lichtenstein, the godfather of thoracic ultrasound. He showed us if you want to differentiate the reason of respiratory failure, either acute heart failure or chronic obstructive pulmonary disease, just put your probe on. That's the normal A profile, so that's lung sliding, seashore sign, whatever you want. And if you have the B lines, then there's too much fluid in the lungs. If it's on only one side, it's rather the pneumonia. If it's on both sides, it's the cardiogenic edema. So it can help you in the diagnosis, definitely. And then there has been a very good study in Italy from Roberto Coppetti. They were just doing what I want to tell you now. Go in the emergency room, do standard examination, laboratory examination, ECG, X-ray, arterial blood gases, and some of the people got the point of care ultrasound and the others didn't get it. If you do that, and these are the same diagnoses we had here for dyspnea, yeah, acute dyspnea, with ultrasound, the performance was good. Sensitivity, specificity, that's okay. Yeah? Without ultrasound, that's what experienced doctors had. Yeah? So you just need the ultrasound for that. And if you took these patients and you did the ultrasound afterwards, you also had the diagnosis. So it doesn't matter if you do it before or do it at the end, but you need the ultrasound for the dyspneic patient. Okay. How shall we know what our patient has? There are old possibilities, yeah, just give him something, some medications. In fact, the thing is what we already did. We take the history and we ask the patient, is that the first time you have the problem? In our patient, this wasn't the case. How did it start? Acutely, or did it develop over some time? What previous illnesses or pre-existing conditions are there? You can look up in the charts, you can ask the patient. What actual medication do you have? And do you take this medication? That's also important. There are people with acute heart failure, with chronic heart failure, they don't take the medications. That will not help them, okay? You could ask the patient if it hurts, if he has cough, if he has allergies, and if he has been immobilized or something, yeah? So that's the things you could ask him, and that could give you a clue what is the reason for the dyspnea. Then you could do some scores. We already know the Wells score. Then there's the CRB 65 for people with pneumonia, with CAP. There's the Q-SOFA for septic patients, but there's not much more, yeah? The PSI and the PASI are just severity scores, yeah, pneumonia severity score and pulmonary embolism severity score. So they're not good to find out what is the reason for the dyspnea, but they are good to find out what do I do with the patient, yeah? And then you do what you always do. You already know that. A, B, C, D, E. And yesterday, Christopher Moore presented you there. You need the U, so we need the ultrasound. But you do just normally, you assess your patient and you look what is the most threatening problem for him. Is the airway patent? Does he breathe normally? Does he have difficulties in breathing? What about circulation and everything else? How do you do a clinical exam? You look, you touch, perhaps you could do percussion, but that's not so easy. And you do auscultation, so you listen. Look, touch, listen. That's the sounds, that's the senses you can use for it. How do you do it? There are some things you see from distance. That's what I told you with my patient, yeah? I wasn't even in the room and I already saw the patient had paradoxical breathing, for example. You could even hear wheezing from distance, yeah? You see the skin color. You see if the patient is using his auxiliary muscles, yeah? If the sternocleidomastoideus is coming out. So that's all things you see from distance and you already see patient is altered or not. If you go nearer, you can do auscultation percussion. You can see if the patient has retractions when breathing, yeah? You can also feel the temperature already, yeah? And then there are signs that are not directly linked to the respiratory system, but still they are linked to it, so you should assess them. Ankle edema, as we know, venous congestion, cold sweating patient. A cold sweating patient is really severely threatened, yeah? Altered mental status, tachycardia, so everything that can happen. And then what do we do with that patient? We say, is he at risk or not? Do we have to act immediately or do we have a bit of time? If the person is alert and awake, his mental status is okay, at least one good thing. Is the airway patent? We always have to assess that. We have to assess the breathing. Is it too slow? Is it too fast? Or is it a bit strange? So does he have retractions? Does he have paradoxical breathing? And then we also look at his face color and we look at his pulse. And if something here is altered, we have to act immediately. If these things are just normal, we can go on and we can listen to the patient's chest. If he has symmetric breath sounds, it could be inspiratory, the stridor. That's extrathoracic stenosis, yeah? So up to the bifurcation of the aorta, of the trachea. Upper airway stenosis, foreign body aspiration, vocal cord dysfunction, sometimes a laryngitis in children, yeah? If it's expiratory, wheezing, so that's either from the lungs, asthma, COPD, it's from the heart, edema, or it's other reason of edema, yeah? Non-cardiogenic pulmonary edema. And then there are the crackles. If they are from the lungs, they come from the lungs. It could be pneumonia, fibrosis, bronchiectasis, or it could also be cardiogenic edema, yeah? So that's the symmetric breath sounds. And with the asymmetric breath sounds, you have to assess further. You have to palpate, to do percussion. If you hear dullness, then it's something too much in it, yeah, either too much fluid or too much tissue. So pneumonia, atelectasis, or pleural effusion. And if it's hyperresonant, there's not enough tissue in it, so it's either pneumothorax or emphysema. That's what you can do to assess the airway and the breathing of the patient. And what you also should do anytime is the arterial blood gases. That tells you so much. So apart from ultrasound, that's your most important tool, I think. You can assess circulation and disability. For circulation, the ECG, of course, we do that, the blood pressure, the pulse, but we already heard we don't know how much this will really help us. And then there comes the exposure. And exposure in that situation, in that patient, is for me the imaging. And the imaging is the ultrasound imaging because we said that's the only thing we can use here on the point of care without any problem. If I would do an X-ray with that patient, that would be a real problem. The patient is running on noradrenaline 1.1. He's running on dobutamine, 10 micrograms. And every time you touch him, his saturation goes down to about 70, and his blood pressure goes down to about 50. Yeah? So if you try to do an X-ray with that patient, first thing is the X-ray on the supine patient is a problem. You don't get much information, and perhaps you could kill the patient with that. So I put the ultrasound probe in, and I see something. I could put the ultrasound probe on the lungs and see something. I could put it on the abdomen. It's just perfect way to work. And that's what I told you. You get a good information with it. Can you do all these things? Huh? You can. Taking history doesn't take a long time, perhaps doing a score. Examining the patient in the emergency situation shouldn't take longer than 2 minutes normally. Then you could do all these tests. Focused ultrasound doesn't take you too long. If you do a full thoracic ultrasound, of course, that will take a longer time. But if you send the patient to the CT or do a conventional X-ray, it's just the same thing. You could do some things that don't take too long. In fact, you have to know what's happening to the patient and what you will do now, what's your action in maximum 5 minutes if the patient is really dyspneic. What are the problems with the dyspneic patient? Patient who has COPD, like the patient we had now, could have myocardial infarction, pulmonary embolism, and pneumothorax because COPD patients have that more often than non-COPD patients. Yeah? If you have a COPD patient, the likelihood to get one of these conditions is higher than for everybody else. The next problem is cardiogenic pulmonary edema. At the beginning sounds like asthma, or like, as you called it, cardiac asthma. Sounds like COPD. You don't know what it is. As long as the fluid is only in the bronchial wall, the bronchi get constricted. They have a reactive constriction as well, and then it just sounds like asthma. If you don't hear pathologic breath sounds, that's not always a good sign. Because if you don't hear breath sounds at all, that's mostly because the patient is hyperinflated and will die soon. If you say, hey, it's hyperresonance, it's unilateral, that's a pneumothorax, I will drain it, don't drain the bulla. And with the ultrasound, sometimes you can differentiate pneumothorax from a bulla, but it's quite difficult. And as you already know, the myocardial infarction is difficult to detect. So that's the problem with the dyspneic patient. We know what causes dyspnea in the patients. We know how to assess it, but still, sometimes we are not so good in our differential diagnosis. So let's go back to our patient. He was alert. He showed reactions. He had dyspnea when speaking. Arrhythmic pulses, tachycardic, facial cyanosis, distended jugular veins. Leg edema, paradoxical breathing, wheezing, crackles. What is the differential diagnosis now? We said COPD, congestive heart failure, thromboembolic disease, or pneumothorax. All the others, I think, he didn't have pneumogenic sepsis, he didn't have pleural effusion, anemia, allergy, no. So what do we do with that patient? We go back to our SOP. He had symmetric breath sounds, he had the wheezing on both sides, expiratory wheezing, so it could be all of that. He had crackles, so could still be a lot of diagnosis, and there was a little asymmetry because he had the crackles just on one side, so we should also see if it's one of those diagnoses. So we still have too many diagnoses. You want to have the ECG. What's on it? Patient is tachycardic. It's written with 25 millimeters per second. Yeah? So that's about 120, 130 the frequency, 125 we said, I think. What else do we have? We have here altered descending descending ST segments and the negative T. What else do we have? Atrial fibrillation, yeah. We already know he had it. I'm not sure here. Could be sinus for the moment. As long as I'm not sure, I say rather atrial fibrillation than sinus. But okay. AV, if it's atrial fibrillation, we can't see an AV block. Either AV block or atrial fibrillation, because we need a P for the AV block. Could be. I didn't measure it. I just said it's quite quick. There are some changes that he didn't have 2 weeks ago, but with a patient who has 125 beats per minute for a longer time, you can get ischemia. Yeah? So we don't know. What next did we do? We take arterial blood gases. What is it? No, patient is not going so well, huh? So he is acidotic, he has respiratory acidosis, he has a metabolic part, so he has mixed acidosis, respiratory part, metabolic part. He has oxygenation, that's okay, PO2 of 80, it's enough for that patient. Saturation 85, okay. He does not have anemia, no electrolyte disorder. What do we do with that patient? Either non-invasive ventilation or intubation, yeah. Patient needs ventilatory assistance in every case. Yeah? As long as he's alert and he will cooperate, we can try non-invasive ventilation with him, and that's what we did. I gave him the NIF mask, and I brought him to the intensive care unit of Peter, and Peter did the result. Yeah? I couldn't do it. That was his ultrasound image. So what did he have? Cardiogenic pulmonary edema. On my emergency record, there was written acute exacerbated COPD. I'm the pulmonologist, and I did the wrong diagnosis. But I did the right therapy, and that's the most important thing. Yeah? So sometimes you don't know. And even I knew the patient. I knew a lot about the patient because he was on my ward for 2 weeks. I saw the signs. I could treat him, but I could not find the right diagnosis. And that's the problem with the dyspneic patient. Sometimes you don't know. But as long as you do the right thing, you give him oxygen if he needs, you give him pressure support if he needs, the medicaments, the drugs, the pills are not the most important thing in the dyspneic patient. Yeah? He won't be cured from that. And what else do I want to say you? I already showed you this study where they said that arterial blood gases are valuable in the evaluation of a patient with dyspnea. Many people have more than one causes. Perhaps this patient also had an exacerbation of his COPD. Perhaps he also had small pulmonary embolisms. We don't know. The leading thing was the cardiogenic pulmonary edema, but many people have more than one reason for dyspnea, especially the elderly ones. So always, if you have a diagnosis, think, could there be something different again? Yeah? The reasons for dyspnea in the young patient: pneumothorax, venous thromboembolic disease, asthma, acute coronary syndrome, and pneumonia. That's the most frequent reasons for it. So if you remember that, that's okay. If that's the 12% you remember in 2 weeks. For the elderly patients, it's the COPD and the comorbidities. So we said the pneumothorax, the myocardial problems, acute pulmonary edema, pneumonia, and also VTE, so venous thromboembolism, and it's often more than one reason. Are there any questions? Patient with dyspnea. How do we assess him with ultrasound? That's what Peter will do now. Thank you for inviting me. Thank you. Greetings to everybody.
Well, thank you as well, Otmar. It was a great talk. I think with a lot of applicable stuff that we can really use when we get into the hospital. Are there any questions on the video conference from Hamburg, Berlin, Vienna? Well, I think for now, no questions. If any come up, we'll definitely direct them to you and answer them. You've got one. Please.
You just told us that we might make the difference between a bulla and the pneumothorax on ultrasound could you maybe just explain it a bit more, how I would expect a bulla?
A bulla looks the same as an ultrasound. Yeah? If there's a big bulla, you just have air. Very often it doesn't move, so you don't have lung sliding. It looks like ultrasound. It looks like pneumothorax. In pneumothorax, you could have the chance of seeing a lung point. In the bulla, you don't see that. So that's, if you see the lung point, you say it should be a pneumothorax. You never know, yeah, but it's quite difficult. And without CT, you will never be sure. But with the lung point, at least you have more clues that it is. And there are not so many people with big bulla, yeah. And if they are, most of them know it. So you will see an old record where it's written, yeah.
So usually you would decide to drain it.
If he has an indication for a drainage, because I think it's tension pneumothorax, I would do it. Yeah? And there are examples. For a good friend of mine once drained the distended stomach that has, in a traumatic patient that has been positioned in the thorax, and he put the thoracic drain in the stomach instead of the pneumothorax, because there was no pneumothorax. Still, he helped the patient. The patient could breathe again because the distended stomach was making the thorax too small and diverting the heart. So even if you drain the wrong thing, it could help him. But that's by chance, yeah.
Any other questions? Well, in this case, thank you. We've got a small thank you present for you as well. Thank you.
Thank you.
I think if I understood it right, you took time off work today to be here, so.
Yes. I'm on call right now, and I'm going back to the hospital in the countryside, as you said in the introduction. So,
well,
nice.
perfect.
Schwarzwald Klinik, yeah.
Almost. Well, thank you so much. It will be a few more minutes before we continue with the next lecture. Just 2 or 3 minutes. Give us time to build up here, and we'll continue right away, and we'll have a break after before we do the zone board round.